Today's video is about lithium and its potential value for the prevention and treatment of Alzheimer's disease. But before I speak more about lithium, I would like to start off with a quick intro on Alzheimer's disease. As most of you probably know, this is a progressive neurodegenerative disorder which is characterized by cognitive decline and memory loss. Alzheimer's disease is caused by the damage to nerve cells, so-called neurons, in the brain, and it is the predominant cause of dementia, accounting for approximately 60 to 80% of cases. The scary thing is that the global prevalence of dementia is growing rapidly, as you can see from this graph, which I copied from a Lancet Public Health article. The authors of this article suggest that there will be 2.7 times more dementia cases globally in 2050 than in 2019. In other words, there were 57 million cases of dementia globally in 2019. In 2050, there will be 153 million cases. Of course, this will be a huge burden for society and our health system. Therefore, it's very important to understand the pathophysiology of Alzheimer's disease better and to look for ways to prevent or treat this disease. Now, without going into too much detail here, I want to briefly touch on the pathophysiology of Alzheimer's disease. This disease is characterized by two major hallmarks. First, the progressive accumulation of so-called amyloid beta plaque, and secondly, the formation of neurofibrillary tangles, also abbreviated NFTs. On a molecular level, and as depicted in this figure, amyloid beta peptides are produced by the altered cleavage of the amyloid precursor protein, labeled here as APP, through the proteases beta and gamma secretase. This leads to the formation of so-called Abeta 40 and Abeta 42 peptides, which aggregate and form oligomers between the neurons, and this plaque leads to oxidative stress and ultimately neuronal cell death. Neurofibrillary tangles, on the other hand, are caused by hyperphosphorylation of tau protein. In normal conditions, tau stabilizes the cytoskeleton of microtubules, which is essential for cell stability and trafficking of vesicles, but under pathological circumstances, soluble tau protein undergoes hyperphosphorylation, and this leads to the formation of NFTs. Now, NFTs lead to neuronal communication dysfunction and collapse of the transport system, which ultimately leads to cell death. Other hallmarks of Alzheimer's disease are synaptic dysfunction, neuroinflammation, oxidative stress, higher activity of acetylcholinesterase, and neuron loss and degeneration. Of course, scientists have tried for decades to identify effective drugs for the treatment of Alzheimer's disease. So far, 8 drugs have been approved by the FDA for the treatment of Alzheimer's disease, and you can see them in this table with the exception of Tacrine, which has been withdrawn from the market due to hepatotoxicity, and the first monoclonal antibody aducanumab, and I will speak to that later. From the remaining 6 drugs, 4 are focused on symptomatic treatment, and the 2 recent ones, the antibodies lecanemab and donanemab, aim at clearing beta plaque. As you can see from the table, the 3 molecules on the left are all acting through the inhibition of acetylcholinesterase. This is an enzyme that cleaves acetylcholine, which is one of the most important neurotransmitters. One has found that acetylcholine levels in the brain of Alzheimer's disease patients are low. Therefore, blocking acetylcholinesterase increases cholinergic activity in the brain. Memantine, on the other hand, is blocking the so-called NMDA receptor. Now, what does NMDA mean? NMDA stands for N-methyl D-aspartate, and this receptor plays an important role in the synaptic transmission and synaptic plasticity, which is not only central to the development of function of the nervous system, but also to neurotoxicity. It has been found that in Alzheimer's disease, there is excess calcium entry into neurons via the NMDA receptor, which leads to synaptic dysfunction and ultimately neuronal cell death. This, in turn, of course, rationalizes the use of memantine as a symptomatological and neuroprotective treatment for Alzheimer's disease. Now, in 2021, with Biogen's aducanumab, the first antibody for Alzheimer's disease was approved. However, a lack of solid efficacy data and a long list of side effects left the physicians hesitant to prescribe the drug, and as a result, the drug was pulled from the market in January 2024. Therefore, I did not list this one in the table. However, lecanemab and donanemab, these are the 2 most recent additions to the Alzheimer's disease treatment landscape. Both antibodies are targeting aggregated amyloid beta and are the novel, most innovative treatments that are available. Now, switching gears to the therapeutic potential of lithium, this slide aims to provide an overview on some of the key findings from both preclinical and clinical studies on lithium over the past years. In terms of preclinical studies, there's a lot of data out there showing that lithium can reduce amyloid deposition and tau phosphorylation, regulate autophagy, inflammation, oxidative stress, cholinergic and glucose metabolism. Lithium can enhance neurogenesis and synaptic plasticity, maintain mitochondrial homeostasis, and improve cognitive function. Based on clinical study outcomes, there are first signs that lithium can reduce the risk of Alzheimer's disease in general, halt the progression of early-stage Alzheimer's disease, and maintain the cognitive stability over extended periods. Last but not least, there is also, of course, a cost aspect here, and lithium may be superior in terms of cost compared to recently approved drugs. According to a paper from Terao, which I highlight here, the cost for anti-AB immunotherapy is $26,500 per year for the antibody lecanemab. And this is, of course, significantly higher than the cost for lithium treatment, which is accounted for only $40 per patient per year. Okay, now time for some history. What many people don't know is that lithium has quite a long history in psychiatry, but of course this would not have been possible without the discovery of lithium itself, which goes back to the Swedish scientist Johann August Arfwedson. He joined the lab of Jacob Berzelius and worked on the analysis of this mineral here called petalite, and this had been found in an iron mine in the south of Stockholm. Now, Arfwedson found that besides silica and alumina, petalite also contained a new alkali metal, which they called lithium, which means stone metal. In 1843, the surgeon Alexander Uhre demonstrated how lithium carbonate, when exposed to uric acid crystals, formed lithium urate, effectively dissolving the crystals. Now, based on this result, he suggested that injection of lithium carbonate solutions into the bladder should dissolve kidney stones that were trapped there. Unfortunately, his work to treat kidney stones with lithium injections into bladder resulted in minimal benefit, but nevertheless, Uhre's work did not go unnoticed, and a few years later, the physician Alfred Garrett, who had documented elevated levels of uric acid in the blood of patients with gout, recommended lithium as a treatment. In 1870, Silas Weir Mitchell, one of the fathers of American neurology, used lithium bromide as an anticonvulsant and hypnotic. William Hammond, 1 year later, recommended lithium for the treatment of mania, and a few years later, the Danish psychiatrist Frederick Lange began using lithium in the prophylaxis of melancholic depression, ultimately treating 35 patients with lithium carbonate. One key person in the history of lithium in psychiatry is certainly John Cade, an Australian psychiatrist whose research at a small hospital in Australia forever changed treatment of mental disorders. He was aware of Garrett's success in using lithium as a gout medication nearly 100 years earlier, and he hypothesized that uric acid might somehow cause the psychotic excitement of his manic patients. He chose lithium as an investigatory drug and treated 10 patients with lithium citrate and lithium carbonate. Some patients responded incredibly well, and they essentially returned to normal functioning after years of hospitalization. Cade's original article appeared in an obscure Australian medical journal in 1949, and although the article has become one of the most widely cited one in the entire history of psychiatry, it went largely unnoticed at the time. For those who would like to learn more about this fascinating story and discovery of lithium for this indication, I can highly recommend the book Lithium, a Doctor, a Drug, and a Breakthrough by Walter Brown. Really cool. Anyways, the real breakthrough in lithium therapy came in 1952 when Erik Stömgren, a Danish psychiatrist, suggested to a staff psychiatrist, Morgan Schau, that he should run a randomly controlled study of lithium for mania. Random controls were just being introduced to psychiatric drug trials at the time, and Schau randomly assigned patients to lithium or placebo by the flip of a coin. The results of the study were quite impressive and triggered the initiation of a number of clinical trials. One difficulty that remained with lithium, though, was the measurement of blood levels, which was almost impossible, but this changed with the introduction of the Coleman photometer in 1958, which made it possible to precisely determine the amount of lithium present in a patient's blood. This advancement opened the door for the widespread introduction of lithium in clinical psychiatry. Interestingly, despite its proven efficacy, it took 10 more years for the FDA to approve it, whilst the drug had long become approved by government authorities elsewhere, for example in 1961 in France or 1967 in Germany. In any case, without the persistence of some researchers to study lithium, it would probably have never been approved for psychiatric indications. To finish up this section of the presentation on lithium in psychiatry, I wanted to read out these two statements that I took from the papers referenced at the bottom of the slide. First one, with the exception of ECT, which is electroconvulsive therapy, lithium is the single most effective treatment in psychiatry. Its side effects are easily manageable, and many patients stay on low-dose lithium for decades. Its benefits in terms of the relief of mania and the prophylaxis of depression are incalculable. Second one, lithium remains the single most effective psychotropic agent in all of psychiatry and has applications in the treatment of bipolar disorder and major depressive disorder. Okay, before I move back to lithium and Alzheimer's disease, I wanted to share a quick fun fact. Did you know that until 1948, the carbonated beverage known as 7-Up was sold as BIB label lithiated lemon lime soda and was marketed as a hangover cure? Isn't that cool? Now, what about lithium in Alzheimer's disease research? For sure, the history is a shorter one, but already in the 1980s, first experimental studies suggested that lithium may possess neuroprotective effects in Alzheimer's disease. Over the next decades, the mechanisms through which lithium plays a role in Alzheimer's disease were more heavily investigated. I will speak to some of those data on the next slides. Importantly, a couple of small clinical trials were initiated, and one major study found that long-term administration of low-dose lithium significantly slowed the rate of cognitive decline in Alzheimer's patients. Interestingly, a recent study by Itsuki Terao, in which they analyzed 8 randomized placebo-controlled trials with 6,547 participants, lithium significantly outperformed donanemab, aducanumab, and placebo in a mini-mental state examination. After all this introduction, the question is, how does lithium work on a molecular level? In the meantime, we know from many publications that one of the primary molecular targets through which lithium exerts its neuroprotective effects is GSK3. Now, what is GSK3? GSK3 is a serine-threonine protein kinase. That means it selectively phosphorylates serine and threonine residues of other proteins, and it was first discovered as a regulatory kinase for glucogen synthase. Now, once glucogen synthase is phosphorylated by GSK3, it is no longer active and cannot be active in the synthesis of glucogen. There are two isoforms, GSK3 alpha and GSK3 beta, and the latter is essential for the control of glucose metabolism, signal transduction, and tissue homeostasis. GSK3 is quite important in many pathways, and over 100 proteins are substrates for this kinase, many of them involved in important processes such as autophagy, cell survival, cell cycle regulation, etc. Importantly, in the context of Alzheimer's disease, it is involved in almost all aspects, such as brain functions, neuronal morphology, synapse formation, and neuroinflammation. And it's also important to know that abnormal increases in GSK3 beta levels and activity in the brain are associated with the pathogenesis of Alzheimer's disease. According to literature, and I provide the references as usual at the bottom of the page, lithium inhibits GSK3 activity through 3 distinct mechanisms. First one, lithium, which has an ionic radius similar to magnesium, competes with magnesium 2+ ions to bind the catalytic site of GSK3, which is necessary for enzyme activation. Secondly, lithium indirectly inactivates GSK3 beta by activation of ACT, another kinase, which in turn phosphorylates GSK3 beta, so in essence through a feedback mechanism. And thirdly, lithium seems to inhibit mRNA transcription of GSK3, reducing its expression levels. On the next few slides, I will discuss in more detail how lithium influences molecular pathways that are important in the pathogenesis of Alzheimer's disease. The first important effect of lithium is its influence on the amyloid beta pathology. You've all learned in the beginning of this presentation that the abnormal production of R-beta peptide is a crucial step leading to neuronal loss and death, and that beta and gamma secretase are important for the formation of R-beta. Now, lithium inhibits GSK3 beta, as we just learned, and with that increases nuclear beta-catenin levels. Now, beta-catenin translocates into the nucleus and leads to its interaction with TCF4, which binds to the base 1 promoter. Now, this results in inhibition of base 1 transcription and ultimately leads to decreased R-beta production. Lithium can also decrease gamma secretase levels. Another important aspect is the following. At the blood-brain barrier, R-beta clearance is facilitated by R-beta trafficking proteins such as LRP1, which are essential for maintaining low levels of R-beta in the healthy brain. The administration of lithium leads to the upregulation of the blood-brain barrier microvessel efflux transporter LRP1 and an increase in CSF bulk flow. This enhancement promotes the clearance of R-beta by facilitating R-beta efflux and improves cognitive function in mouse models. In the introduction, I also mentioned that in Alzheimer's disease, tau hyperphosphorylation leads to the formation of intraneuronal NFTs, which of course disrupt normal axonal messaging and ultimately cause cell death, which is another important issue in Alzheimer's disease. Now, cortical neuronal cultures exposed to lithium exhibited reduced levels of tau mRNA and protein expression. And in another study, chronic lithium administration was observed to attenuate tau pathology by increasing tau ubiquitination. Another way for lithium to interfere with tau pathology is through its inhibition of GSK3 beta, which is also involved in tau phosphorylation. Autophagy is a very important cellular process in which misfolded proteins, damaged organelles, and other trash of the cell is degraded. Autophagy also plays an important role in Alzheimer's disease pathogenesis by facilitating the degradation of R-beta, phosphotau, and damaged mitochondria. Now, lithium enhances autophagy through inhibition of inositol monophosphatase, which leads to a depletion of free inositol and decreased levels of inositol 1,4,5 triphosphate. And it is known that reduced levels of IP3 stimulate autophagy. Neuroinflammation is another crucial factor in the development of Alzheimer's disease. Many studies suggest that the overactivation of microglia and astrocytes, as well as the inflammatory molecules they produce, can disrupt the neuronal microenvironment and lead to cognitive impairment. As a GSK3 beta inhibitor, lithium reduces transcription activity of NF-kappa B, which actually leads to a decrease in the release of pro-inflammatory factors and glial cell activation. And some studies also show that STAT3 is downregulated by lithium treatment, resulting in reduced secretion of pro-inflammatory cytokines. Last but not least, mitochondrial dysfunction, oxidative stress, and apoptosis are all significant factors in the pathogenesis of Alzheimer's disease. Lithium can reduce reactive oxidative species or ROS levels through increasing NRF2 levels, which in turn enhance the activity of factors like superoxide dismutase or glutathione peroxidase. With regards to apoptosis, a study found that in patients treated with lithium, there is an increase in the expression of BCL2 and a decrease in the expression of several pro-apoptotic proteins, leading to reduced apoptosis. Finally, lithium has been found to play an important role in regulating mitochondrial function. The peroxisome proliferator activated receptor gamma coactivator 1-alpha is a crucial regulator of mitochondrial function. GSK3 beta inhibition enhances PGS1 alpha protein stability, nuclear localization, and transcriptional coactivation, leading to improved mitochondrial energy metabolism. In terms of real-world evidence, several clinical trials have shown beneficial effects of lithium supplementation in the treatment of Alzheimer's disease. This table here shows a couple of past or ongoing clinical trials, and I just wanted to highlight a few here. First up, analysis of cognitive and functional status conducted recently, 13 years after enrollment in a lithium therapy trial, revealed that older patients with amnestic MCI, so mild cognitive impairment, who were treated with lithium had better long-term cognitive outcomes than a matched sample without treatment. The study suggests that lithium treatment may provide long-term and sustained neuroprotective benefits. To separate randomized clinical trials conducted on patients with amnestic MCI have shown that chronic lithium treatment can reduce cognitive decline. Additionally, it can decrease CSF levels of phosphotau and increase CSF levels of R-beta 142. Many more studies, especially on microdosing of lithium, are currently ongoing, and it will be very interesting to see the outcomes. Of course, all this data begs the question whether it could make sense for a healthy person to supplement lithium given its beneficial effects. Now, certainly not in the dosages that are used for the treatment of psychiatric indications such as bipolar disorder. Here, patients usually take 600 to 1200 mg per day, and this leads to a blood exposure level of 0.5 to 1.2 millimolar. Doses higher than 1.5 millimolar can actually be toxic and can lead to damage of the kidney, the thyroid, the parathyroid glands, etc. Importantly, however, these are rare adverse events associated with high-dose lithium therapy. And this have unfortunately instilled a stigma with lithium, leading to an underappreciation of the potential benefits of low-dose lithium supplementation. As a matter of fact, there is a growing body of scientific evidence showing the beneficial effects of lithium microdosing. What is quite interesting is that epidemiological studies have shown that exposure of trace lithium in tap water is inversely correlated with hospital admission for mental health, aggressive behavior, all-cause mortality, suicide mortality, cardiovascular mortality, Alzheimer's disease mortality, and the prevalence of metabolic diseases such as obesity and diabetes. And there's actually a lot of nice literature you can read if you're interested in this topic. Now, for all those people out there who want to take a deeper dive into the benefits of low-dose lithium supplementation, I can highly recommend this article here from Fajardo, published in 2023 in Current Neuropharmacology, and this really goes into detail of all the studies that have been performed using low-dose lithium. With regards to supplementation, I personally and periodically take 1 mg of lithium per day, which leads to a concentration of 0.0014 millimolar, which actually equals the essential daily requirement as proposed by Schrautzer in a 2002 paper from the Journal of American College of Nutrition. But again, I do not provide any medical advice here in my video, so please do your own research. Anyways, this brings me to the end of my presentation. I really hope you liked it. If so, please subscribe to my channel and stay tuned for more content.